Happy New Year. It's been a few weeks since we've spoken. I will start by sharing information, which unfortunately, as people know from seeing the news, there is a fair amount of update on our corona.
Andy, you're muted.
Not sure who muted me there, but anyway. Okay. So much like what we've heard around the country, we saw a significant rise in COVID infections in the month of December, particularly the last 2 weeks of December. 110 people we support tested positive for COVID in the month of December. If you add up every single month on the chart that you see, you'll see that it adds up to 567. To date, we've had 558 people who have tested positive. This includes 9 people who've tested positive twice. 7 of those who tested positive twice were in December of 2021. Only one of those who tested positive twice in December was unvaccinated. So breakdown by placement type. We've had 1 person in a correctional facility at DC Jail who has tested positive, 13 in host homes, 118 in intermediate care facilities, 1 in a mental health facility, 104 in their natural homes, 2 in nursing homes, 6 in out-of-state placements, 44 in residential habilitation, and 270 in supported living. You may notice the biggest increase that we have seen has been in supported living and natural homes. So in ICFs, the 118 people represent just about 40% of people in ICFs. Of those 118 people, 28 of them have died, but only 13 are confirmed COVID deaths. So that represents about 11% of people in ICFs who contracted COVID and have a confirmed COVID death. In natural homes, the now 104 people with COVID represent 11% of people that we support in natural homes. We've had 6 deaths amongst those 104 people. 5 are confirmed COVID deaths, representing just under 5% of people in natural homes who had COVID and died from a confirmed COVID death. In residential habilitation, the 44 people represent about 40% of people in residential habilitation. Of those, 3 people have died, but 2 were confirmed COVID deaths. So that is also just under 5% of people in residential habilitation who contracted COVID and had a confirmed COVID death. The 270 people in supported living represent about 28% of people in supported living who have contracted COVID. Of those, we've had 26 deaths, but only 15 are confirmed as COVID deaths. So that's about 5.5% of people in supported living who contracted COVID and had a confirmed COVID death. So overall, the 558 people supported by DDA who have contracted COVID represent about just under 23% of people supported by DDA. We have had 67 deaths, but 37 are confirmed COVID deaths. which represents about 6.6% of people we support who had COVID and a confirmed COVID death. So in the month of December, amongst the primary placement types that we had 4 people in ICFs who contracted COVID, 1 in a residential habilitation placement, 58 in supported living, and 41 in natural homes. In the first week of January, we've had 5 people. That's been 4 in supported living and 1 in a residential habilitation placement. Of the people who contracted COVID, 7 have required hospitalization. I am happy to report none of those people are in the hospital today, so they've all been discharged successfully from the hospital. Interestingly, of the 7 people who have been hospitalized, 5 had been vaccinated. None of them had, all of them were eligible for, and none of them have documented boosters. And then 2 of them were people who have not been vaccinated. Oh, sorry, here. Didn't correct this number at the top. So of the 67 confirmed deaths to date of people who've contracted COVID, 16 have been confirmed as not COVID related, and we are still awaiting the cause of death on 14. There was, as we note here, one person died in December. That's a person, they had COVID. It was in November of 2020, and they had fully recovered. So confirmed COVID deaths, the last one that we had was in March. Among provider staff, we've seen the same thing. We are now up to 915 provider staff who have tested positive. Oops, sorry. 915 provider staff who have tested positive for COVID-19. 58 of these staff have been reported by more than one provider, and it is still 10 staff who have died from COVID. Vaccination rates. Unfortunately, it stays around the same. We're at 82% for people supported by DDA. In host homes, that's at 90%. Intermediate care facilities is 98%. People may have noticed that went down by 1% because we had a new person move in who was not vaccinated. Natural homes, 65%. Residential habilitation, 97%, and supported living, 91%. Among our provider staff, we are at 95%. That gets updated every other week, so we'll see what next week brings. And then amongst DDS staff, we are at 94%. People may be aware for DDS staff that that in the recent mayor's order, she has instructed the city administrator to establish a process by which we will be eliminating the option to test weekly rather than get a vaccine, and a requirement that people receive the booster shot when they're eligible. And so we will see, we expect to see an uptick in that number. For some reason, I'm having a problem getting my WebEx to maximize again so that I cannot see questions or anything that's in the chat. And I'm not sure why. Usually as soon as I assume people cannot still see the presentation. Ah, there it is.
Correct. Okay.
Okay, it finally finally came back for me. When I have a presentation up, I just have a really small WebEx screen.
I have one question, Director Reed.
So I do see, can I break down where the 110 people who tested positive live? Yeah, that was broken down in one of these slides. Wait a second. So this isn't the whole 110 because but the major placement type. So among ICF, ResHab, supported living, and natural home, and this is all but about 6 of them. So of the oh, and I'll pull up my list and tell you what the others were. Hold on one second, sorry.
Hey, Andy, I think Sandy stated that she asked a question before you presented that slide.
Oh, okay. So I don't need to keep looking. Is that what you're telling me?
Well, that's what I believe she said.
Although Robin has asked the same question though.
Oh, okay.
Okay, so what we had was in the month of December, 58 people in supported living, 41 people in natural homes, 1 person in residential habilitation, and 4 people in NICF. And I'm pretty sure that that was actually 1 ICF. But I'm going to look now just to confirm that. We also, as I said, had 7 people who tested positive for the second time. So it was 3 people in 1 ICF and 1 person in another. And then we also had three people in host homes, 4 people in host homes, 1 person in an out-of-state placement, and 1 person in DC jail. Question for DC Health, which is actually related to a question that I also wanted to pose to DC Health, because so their question is, if a person's primary care doctor recommends a 7-day isolation versus a 10-day isolation for a person who tests positive, are providers able to follow that direction, or do we need to continue to implement the 10-day isolation guidance?
Hi, Director Reese. So that is a question that has come up before, and what I can say is, without knowing the details of the recommendation or the circumstances, that DC Health provides best practice, essential best practice recommendations to mitigate the spread of COVID-19. And to date, DC Health has not changed isolation recommendations for persons supported. It still recommends a 10-day isolation. And so to answer that question, they should continue to follow DC Health's posted guidance for 10 days.
So related to that and kind of going the other direction, could you also explain, please, Nelson, the role that testing plays in ending a person's isolation? Because as I go through all these cases, I'm reading a bit too often, frankly, that people are waiting for sometimes even 2 negative tests before ending isolation, or they're waiting 14 days and for a negative test. So could you clarify exactly what the guidance says about ending isolation for someone who has COVID?
Sure. So this question is answered on coronavirus.dc.gov/health guidance under the guidance titled Discontinuation of Transmission-Based Precautions for patients with confirmed or suspected COVID-19 in healthcare settings. This would also apply to these settings as well. And so a test-based strategy is not actually recommended under normal circumstances. The guidance says that as an exception, a test-based strategy may be considered for some patients, or in this case, persons supported, who are severely immunocompromised or with critical illness. If concerns exist for infection to last more than 20 days, which is outlined as an option for severe illness for those that are immunocompromised in the guidance. The decision to use a test-based strategy must be in consultation with an infectious disease expert and must not be used to discontinue transmission-based precautions earlier than if a symptom-based strategy was used. And so if a person does not meet the criteria for severely immunocompromised or with critical illness, and there aren't concerns for them being infectious longer than the 10 days or even 20 days, which can be the case for immunocompromised, and they've consulted an infectious disease expert that suggests that a test-based strategy is used, then they should be using normal symptom-based strategy or time-based strategy for asymptomatic individuals.
Thank you. And there's a question about the vaccination status of the 110 people who tested positive. I want to provide a caveat to this, first of all, which is we will be following up. We have requested for people to be updating the status of people getting boosters. And, you know, I think that people have been hearing and will continue to hear the importance of getting a booster. As I just mentioned, with the 7 people who were in the hospital, none of them were what the CDC would consider current with their vaccination status. 5 of them were what we call fully vaccinated, in that they had gotten either 2 of one of the mRNA vaccines or they had gotten 1 of the Johnson & Johnson vaccine. But for all of them, it was long enough ago that they were due for a booster, and there was no evidence that they had received that booster. And the data that we have right now on boosters is not good. And so for one, we need to make sure that, and we'll be reaching out in the next week to redouble these efforts, make sure that people are getting their boosters, and then we'll be making sure that people are able to and are uploading that so that we can track that, that data as well. But in terms of vaccinated, as the prior term meant fully vaccinated, one of the challenges with data with this is that the guidance continues to change. So, we're tracking when you're due for a booster, and this week they've changed that. So it is challenging, but fully vaccinated only as defined by having either 2 of the mRNA or the 1 Johnson & Johnson shot. Of the 110 people who tested positive in the month of December, 92 were vaccinated. And 18 were unvaccinated. Of the 18 that were unvaccinated, it was 8 in supported living, 7 in natural homes, and then 1 each in an ICF corrections and a host home. And as I said, I think it seems, based on the data I'm hearing from the news, which I expect everyone has access to hearing the same thing, how important boosters are to people maintaining their health. So it is essential that everyone get the booster. And as I say, we're going to redouble our efforts to make sure that those are being documented so that we can clearly track them. For the folks who were hospitalized, I was tracking not only what we have in MCIS, but looking at the CRISP medical data to see if it had been entered, and I saw no evidence for any of them that had been done. Okay. So the mayor's recent order was a bit vague as it did not drill down on unlicensed healthcare professionals. Will there be more guidance and specific timeframes for the booster mandate? Just to be clear, the mayor's order that addressed the requirement for a booster and eliminated the ability to test weekly in lieu of getting a vaccination was directed to employees of the District of Columbia and contractors. And the guidance that we had received from the city administrator following the original order that applied to employees and contractors clarified that that was referring to contractors that provide services directly on our behalf, who work out of our building, for example, the guards that are in the lobby. It did not apply broadly to everyone who has a human care agreement with our agency. And so those requirements regarding vaccination for healthcare professionals and our DSPs are covered by the DC health regulation change that required all licensed professionals to get vaccinated, and it also required it changed the qualifications for Medicaid providers so that folks who provide direct service also had to be fully vaccinated, and that I don't believe has changed. Oh, I've asked Beam to be a panelist. I hope that he is. In anticipation, people may be aware with the new year, we did launch the new MCIS. The old MCIS is still available for historical data, but for entering new data, people need to go to the new MCIS system. And so the question is, are we using the old system instead of the new system moving forward? No would be the answer to that question. The link that was provided at the beginning of the meeting takes us to the old MCIS page compatible with Chrome. And so maybe Beam can speak to the link that was provided at the beginning. I don't know if I see Beam here.
Yeah. Good afternoon, everyone. The link I provided is the old system link. So, but whatever the issues are open, you can upload the supporting documents there. That is the main reason. So in the new system, we are not transferring any issues, incidents, and any other information. In the new system, the incident, issues, and provider documentation, everything is available in the new system. Old system link we provided, some of the providers having issues to access from the new system. That is the reason we provided another link to upload the supporting documents to close the issue.
Thank you. And we do appreciate that it can be a little bit challenging right now, but at this time, both are available so that people can see historical data and enter new data. Someone has asked, when EVV has issues and when staff have issues signing in to SAN data, what should providers do? I think it's evv@dc.gov. I'm hoping that Donald is either a panelist or is here today. We have provided that contact information previously. There's an email address that at DHCF when there are issues with EVV. And we will try and make sure and post that before the end of this meeting. Oh, Nelson, I believe they're referring to you. It said, can you provide the name of the guidance that you were reading from before regarding?
I put it in the chat.
Thank you.
I can answer this next one. Will being boosted be added to the definition of fully vaccinated? We are getting a lot of those questions, and there's ongoing discussions with the CDC. Currently, what's posted is unchanged, and there isn't a change in the definition of fully vaccinated. However, CDC has let us know that we can anticipate some updated language in the very near future. So when that happens, DC Health will update our guidance accordingly, and it will be posted, and we'll certainly let you know when that happens.
This says, does this mean that DDS and day programs will stop asking for negative tests for people who have previously tested positive? DDS should not be asking for that. So I would say as it relates to DDS, absolutely. For day programs, if I would recommend to day programs who have concerns about when to readmit people after they have had COVID, that they should speak with DC Health.
I agree absolutely, Director Reese. And I'd also like to add that there's a big difference between requiring a negative test for someone to return to an activity, a group setting activity like that, and requiring a test for them to come off of isolation where they're confined to their room and isolated from others. And so those are really two very different and separate instances where a test is being required.
So are we saying that once a person completes their time-based isolation, they don't need a test to end isolation? That's exactly what I heard.
That's correct.
Especially for those who are fully vaccinated and boosted, but were exposed or tested positive. Keeping in mind that those are two different things, and maybe you can walk through each of those, Nelson. Someone who's had an exposure and is quarantining is different than someone who's isolating because they have COVID.
So I'm not sure I understand the question.
Ending isolation or quarantine for a person who's been exposed or tested positive. So people are quarantining, and if they live in any of our group settings, if they have an exposure, they're expected to quarantine for 14 days, correct?
That is correct. Yep.
And I do know from having been with someone caring for someone who had COVID, where they ended their isolation after 10 days, but my quarantine lasted 14. There is something in your head that says, wait a minute, but that is exactly the rule, because I don't know when I might have gotten it from them. And so that is the reason that when you have an exposure, that you need to quarantine for 14 days. And if people look at the guidance that DC Health has on coronavirus.dc.gov on that quarantine issue, It's very good from my perspective. What I really like about it is that in the beginning, it really explains the difference they see in transmission rates ending quarantine at different times. And it provides then the basis for the guidance that it gives about when to end quarantine.
So I can answer a couple of these other questions together. They're asking about the difference between exposure and someone who's boosted and someone who's not boosted. So for healthcare, those that qualify in healthcare settings, we have not changed or differentiated an exposure to carve out those that are boosted or fully vaccinated versus those that are unvaccinated. So in a healthcare setting, an exposure is still an exposure. If that changes, of course, we will update our guidance and let you know at that time. But for those that are covered under those healthcare settings, an exposure is an exposure.
So for employees, there are completely different rules. So,
That's correct.
and that came out this week. And actually, an earlier draft was available last week. And so we had already circulated it, but then the final version was posted on coronavirus.dc.gov, I think either yesterday or the day before yesterday. And what it does, from my understanding, is not only clarify what the rules are for, well, it clarifies the rules for returning to work, but it also establishes processes where, when there are workforce issues, those rules could be amended to allow people to return sooner while putting certain protections in place, and also ensuring that all other necessary measures have been taken before you relax the rules in any way, as well as requiring for license placements authorization from DC Health first. And when we sent this out, we advised people that they should also be checking with DDS's Quality Resource Unit, as well as waiver when applicable. Very good. Thank you, Shasta. So for people that have questions about EVV, you can contact DHCF at evvinfo@dc.gov. So someone asked if we could post the final, it says rules, it's guidance, but regarding quarantine requirements for DSPs. And this is the guidance for healthcare personnel for monitoring, restriction, and return to work.
So just to answer the other part of that question, does DC Health require a formal document that tracks their monitoring? No, DC Health does not, but individual providers can certainly do so. We are also updating our screening in a healthcare setting, which includes screening of staff coming back to work. And so if a facility is operating under or outside a conventional capacity strategy, the monitoring or screening rather is encouraged or will be encouraged to be done during the shift. And there should be some mechanism to track that. So you can anticipate new guidance coming out regarding screening sometime next week that should address the rest of that question. As far as what self-monitoring looks like, it's just that. How that's operationalized is going to be different for each setting. It could be in the form of screening someone in the middle of their shift, or asking them at the end of their shift, they are still feeling well, still feeling okay, their symptoms haven't come back or things like that. So it's very much going to be different and operationalized differently depending on the setting.
So someone is also asking, they say they've seen various interpretations of exposure. Could you provide the definition of a direct contact exposure?
Sure. Direct contact exposure is a within 6 feet of someone who's COVID-19 positive, cumulatively for 15 minutes. So if it's 5 minutes in one instance, and 5 minutes in another instance, and 5 minutes in another instance, all within a 24-hour period, that is considered an exposure. There are different requirements or definitions specifically for healthcare providers who care for those that are COVID-19 positive, and those are outlined in the return to work guidance that somebody provided the link for in the chat.
And someone asked, should providers report a self-reported positive in-home rapid test result in the absence of a documented report from a healthcare provider? And if yes, and I don't really understand this part, but it's for DC Health, so I won't worry. What strategies does DC Health recommend to validate a positive rapid in-home test report and complete risk assessment? Actually, my understanding is when you get a positive test result, it's a positive test result, and there is no need for validation of a positive test result. Is that?
So that's correct. So if you're using an at-home antigen test kit, a positive test is presumptive positive, and it's not needed to confirm. There may be instances where if someone has symptoms and they have negative antigen test results, that a healthcare provider may want to follow up with a PCR for confirmatory testing. But if the test is positive, it should be presumed positive, and appropriate action should be taken.
And it did remind me of an earlier time during the epidemic when in one of the press conferences, Dr. Nesbitt had said, once you get a positive result, you have a positive result and you have to act accordingly. Not only does it not need to be confirmed, but it can't be overruled by a subsequent negative.
That's true. It's not kind of you just kind of test until you get the result that you want.
Exactly.
When you get a positive result, you should act accordingly. That's 100% correct.
So I'll admit I don't remember from our Appendix K the answer to this next question, so I'm going to ask Winslow to respond. If you have people who have to quarantine for 14 days, does the provider get paid a quarantine rate, I assume is the question, when the person has had an exposure?
So if it's a true exposure, the provider can build a quarantine rate. And by true exposure, it is by definition provided by DC Health. Unfortunately, we need to do more education on what an exposure is. We had one case this week where a DSP's child who attended school came in contact with a student whose mother's best friend child had been exposed to someone who believed to have COVID, then prompting the person we serve to be put on quarantine. So the answer to the question is yes, the provider can build a quarantine rate. However, you must be very clear that an actual exposure occurred, not just a friend of a friend of a friend might have been exposed to someone who tested positive. And I understand it's very scary for people and everyone wants to be, careful, but we have to also be realistic, because if we use that example that I gave, all of us would be on quarantine.
The example that feels like it grows just a little bit every time I hear it. But
Well, I mean, for effect, I want to make sure people appreciate the fact that if you came in contact with someone who came in contact with someone who came in contact with a person who tested positive, you are safe.
So next, based on CDC, quarantine is now 5 days for vaccinated staff. Are we obligated to keep 14 days? I believe the 14 days we're referring to is, so vaccinated people, you're correct, it's 5 days, and the 14 days is for the folks that live in group settings supported by DDA.
So I'm not sure where the quarantine for 5 days came from. But if we're talking about and we outline this in the work restrictions for those that are exposed in the return to work guidance, those that are, and I encourage all of you to read that because it's very different from what was posted before. Those who have received all COVID-19 vaccine and booster doses as recommended by CDC, who are exposed, do not have to have any work restriction unless directed by DC Health during an uncontrolled outbreak. They should still be tested on day 2 and 5 through 7. So when we say all recommended COVID-19 vaccine and booster doses, that includes those who are fully vaccinated and boosted. It includes those who've received a second dose of the mRNA vaccine, but are less than 6 months, and will soon be updated 5 months for Pfizer and 6 months for Moderna, from getting a booster. So it means that they're not yet able to receive a booster based on that time frame or recommendation. And it includes those who received a single Johnson & Johnson vaccine less than 2 months ago, because after 2 months you have to have received a booster. So those individuals do not need to be restricted from work unless directed by DC Health. For everyone else, meaning those that are partially vaccinated, are past those timeframes and should have received a booster, and those that are unvaccinated, they should be excluded from work for 10 days after last exposure if no test is performed, or they can be restricted from work for 7 days with a negative COVID test, and then the testing is described in the return to work guidance. So for those that haven't reviewed that and those changes, please do that. They're very different from what was posted before.
So how do we decipher false positives? I think that the safest thing to say is that you don't. When you get a positive result, you take it as a positive result.
In the context where we're at right now, which is substantial community transmission, a positive should be assumed to be positive.
Some providers are struggling to get in-home rapid test kits. Some people cannot go to the libraries where the kits are being distributed. Staff cannot receive it on their behalf because they have a Maryland ID. Is there a provision where providers can get these kits?
So I may have to get back to you on this one. I know there has been some support to certain congregate settings for antigen test kits, but if possible, if we could get that question for the specific setting that it might be referring to sent to coronavirus.hai@dc.gov, we can follow up on that question.
Thank you. What is the quarantine rate for in-home support? I'm not sure. I don't know that there is one. Winslow?
I'm sorry. I looked away. What was the question?
They said, what is the quarantine rate for in-home support?
I'm sorry that I don't have the rates off the top of my head, but all providers should have received through our transmittal what the emergency rates are, what the quarantine rates are. If you would like to email me at winslow.woodland@dc.gov, I will send you, or should I say, we'll have someone resend you the actual rates, because I don't have it right before me.
Yeah, the transmittal did just go out, didn't it?
Yeah, that's what
I
my
know there
point
were
is.
some questions about the transmittal, and we will be answering those questions next week.
Hold on, let me see if I can find it really quickly, and I could.
I don't, so this next question, do we retest in 14 days for people boosted living in our facilities? I don't understand that
I'm
question.
not sure where that's coming from.
So if a person had an exposure,
There's no guidance that suggests that or requires that.
yeah, if they develop symptoms, I expect you'd want to test. But if a person has an exposure and remains healthy, they just stay quarantined for 14 days.
That's correct. If at any time they develop symptoms, they should be tested. But otherwise, there's no. They test twice as what's in the guidance, and then once the 14 days is up, that's it. They're done.
And it says here there's no way to confirm an exposure, correct? We just have to believe our staff when they tell us that they were in close contact with someone during the infectious period of the person who tested positive. That is correct. You should absolutely believe your staff when they say that they've had an exposure, but you also should review the guidance about what that means in terms of their ability to work based on their current circumstances, including vaccination and booster status. The point that Winslow was making was a contact of a contact of a contact is not something that you will then record as a person we support having had a contact. So what we have had quite literally is people reporting that a person we support had an exposure to COVID and should quarantine because the support person had contact with someone who had contact with someone who had contact with a person with COVID, literally. That person that person we support has not had any direct contact exposure and has no reason to be quarantining. That was the reason for making that clarification. The status of medical and religious exemption decisions. Hold on one second. So there's been a little bit of progress on this. Of religious exemptions, they're being considered separately for EMS and HRLA. So for HRLA, there are currently still 1,945 religious exemption requests pending. 11 have been considered and denied. None have been granted. Medical exemptions for HRLA, there are 1,360 pending. 168 have been denied and 31 have been granted. So needless to say, it's slow going with reviewing those. And as I had communicated before, I know that when DC Health was presenting in another forum, they just asked that people please be patient as they continue to get through all of these requests for exemptions.
And Dr. Sharon Lewis promised me that she would be on our call next week. I had requested that she would be on the call today, but she had a conflict. So she assures me she'll be on next week. And to your point, Director Reese, she stated that they're moving through the request for exemptions at speed as fast as they can.
So, I'm going to ask Nelson to respond to this next one. It appears that the new HCP guidance indicates symptomatic people should quarantine for 10 days if positive for COVID. What if you're symptomatic, exposed, and test negative for COVID? It looks as if the guidance stipulates 10 days for this as well. Please clarify.
Sure. So first, I'd like to just clarify that there's a difference between isolation and quarantine. So here you're saying that symptomatic people should quarantine for 10 days if positive. Those people should be isolating, not quarantining. People isolate when they're sick, and people quarantine when you think they might be sick, but you don't know yet. And so there's a big difference when you're reading through the guidance using the terms isolate and quarantine. And if you interchange those terms, you will be confused by the guidance. And so they're very different. The other point is that if someone is symptomatic and exposed and they test negative for COVID, depending on their level of exposure, that's kind of an instance where you might want to consult with DC Health and try to figure out the level, the risk of exposure. There may be a recommendation to test them again to make sure that they're truly negative. But regardless, those that are symptomatic under normal circumstances and under conventional capacity shouldn't be coming to work. So even if they test negative, it's determined that they have some sort of other illness, they shouldn't be coming to work. If they're exposed, they need to follow the guidelines for exposure. And so as I said before, those are outlined on page 3 of the new guidance under conventional capacity. And the difference about when they will need to quarantine is different depending on their vaccination status. And so for those, as I've said, that have received all of the recommended vaccine and booster doses, they don't need to be restricted from work unless they're directed to do so by DC Health. But the caveat is if they are symptomatic and they're sick, they need to follow the return to work policy that the facility has for those that are sick. And so even if they're boosted and they meet that criteria that they don't have to quarantine because of the COVID exposure, they still shouldn't be coming to work when they're sick. So I hope that clarifies that question.
A quick update on Station MD. The budget authority approval is it gets passive council approval by January 19th, I think the date is. And I believe, and Jared would know this, I believe we've gotten over all the other hurdles. We do need to confirm with Station MD that they've gotten or that they will have within the next couple of weeks what they need from DHCF in terms of the becoming providers, Medicaid providers. But I think that we are just about there. The approval of funds that we knew were there has been a longer process than we anticipated, and there have been a number of different hurdles to get over to launch this, but we do expect by the end of January that we should be in place. Does that sound reasonable, Jared?
Sounds very reasonable, Andy. 19th, yes, on the funds during the next couple of weeks. That gives us time to shore up that last item with DHCF that you spoke about with respect to enrollment. So I think that the end of this month is very reasonable.
At the day program, many are requesting to stop service Project Redirect offers virtual services. According to the Appendix K, you can bill for virtual and residential services at the same time. Is anything being done to educate teams, as there still seemed to be belief that it would be double billing, even with the updated Appendix K information? We did do a lot of education when that passed, and maybe we need to do that once again, Winslow, just to make sure that everyone's aware. Now, keeping in mind, if someone's in a day program all day, they're not going to get virtual day services all day, but certainly being able to continue for a short period of time while we go through this current surge, continue some kind of services during the day, you're absolutely right. That is in the Appendix K, and that should be approved. And please, to the extent you're hearing pushback about the ability to do that, make us aware so that we know also where the additional education is needed.
Excuse me.
No, I think that you covered that very well, and I just can't overemphasize enough how with the use of remote supports, we have to be mindful that a person's not going to be sitting in front of a computer for 2 hours to receive a service that is being provided remotely. So, the teams have to agree that this can be provided, that the person wishes to have it provided, and that they have the requisite technology to be able to provide the service remotely. Those have to be thought out. And I sincerely hope that I don't see authorizations for or billing for unrealistic remote support provision, because that would be concerning.
So it says here, Innovative Day is also offering virtual services, and there seems to be some confusion by the residential provider. So Shasta and Winslow, we probably need to just make sure that we're clarifying exactly what the Appendix K says about the ability to provide services to support a person while they get virtual day services, so that we can address that confusion.
I guess I'm concerned that if the team discussed this, and by team, I would suspect that the residential provider is a part of the team, because they would be, prior to the authorization, supporting a person to receive the service remotely, i.e., possibly helping them to set up, logging on, what have you. So I guess I'm confused. Is the concern that the authorization is there and the day provider is seeking to use it without the benefit of having the discussion with all involved? I guess 202-730-1618 is my number, or 202-498-9529. I'll put them in the chat because I'd like to really understand the question a little better.
And Tiffany, if you can also email me the name of the providers that are saying no, we will also have a discussion with the residential providers and the day providers about this topic. But if the residential providers are saying no, I would like to know exactly which providers are becoming a barrier. Thank you.
So it's 1:05. I want to stop, but I do want to make sure this one last question gets presented to DC Health. Does PPE affect direct contact exposure?
Sure, so I put this in the chat just in case there wasn't time, but yes, for healthcare providers, it absolutely does, and this is in the table of the guidance. So please, it's defined there. Also, just to touch on providing scenarios, it's really not possible for us to incorporate every possible scenario when we write our guidance, and so we do our best to make it as clear as possible. I will say that the new return to work is more complicated than the previous guidance, and so I do just want to acknowledge that, and we're not surprised that there are a lot of questions. The CDC's recommendations were also very complicated, and so we did our best to translate it into a format that's as clear as possible, but there are going to be circumstances or situations where you might not know what to do, and so that is when you would reach out to DC Health with questions, and we're happy to answer those questions. Some of you do already. I answered a couple this morning, for certain settings and providers. So please go ahead and email us at coronavirus.hai@dc.gov, and we will do our best to answer those scenario-specific questions that you may have.
Okay, thank you very much. And I see we're running over. So, and I recognize it's been 3 weeks since we talked, so not surprising that there were lots of questions. Everyone, please continue to make every effort to stay safe and healthy. And as I said before, you know, we really need to push much harder on ensuring that everyone has their boosters, so that people are as protected as they can be, and we can get back somewhat to normal. Talk with everyone next week.